superior, transconjunctival. So you can attack the orbit in almost 360 degrees, depending on the site of the lesion and the nature of the lesion. So coming to the anterior approach, the two commonest approaches are the Litte crease approach and the sub and the suprabro approaches. So the Litte crease approach is usually very commonly employed incision, because the incision is actually hidden in the Litte crease, and you get very good cosmetic scars. It just looks like a normal Litte crease after the surgery, and the patient does not have any scarring at all. So you can see in this patient, a young male patient who's got a big lesion in the superior orbit, anterior superior orbit, pressing the globe down, causing an inferior proptosis. And you can see it is quite accessible. It's not very deep. It's quite anteriorly placed right in front of the globe and superior to the globe. And you can actually plan to remove it with a simple Litte crease incision like this. So you just mark the Litte crease of the patient and place your incision right on top of the Litte crease. And you will reach the lesion straight away. And this usually is a very well hidden lesion, and within few months, actually, the patient will have very good scarring. Again, one more example, you can see a very young male who's got a right eye eccentric proptosis due to a huge lesion sitting on top of the globe. And through a Litte crease approach, you can see we've removed quite a large cystic lesion. And though the cyst was very large in size, you can see post-operatively in the first week itself, the patient has got a very good scar. And within few months, he will be absolutely normal. So this is going to make a big difference to the patient, because lifelong, the patient will not have a scar which he will have to live with. So the Litte crease approach is a very commonly employed incision. And actually, for even bigger lesions like the lacrimal gland lesions or huge lesions, you can extend the Litte crease. You can do an extended Litte crease incision into one of the smile lines on the lateral canthus, and you can get away with very good scars. And again, for huge dermoid cysts which are in the anterosuperior orbit, you might need to employ the extended Litte crease incision, where you just slide it across into a smile line on the lateral canthus. Again, one more young female patient with a superior orbital lesion, a schwannoma. And you can see we have done a Litte crease approach and removed the lesion with very minimal scarring. So for lesions which are slightly more superiorly placed, which are not just behind the Litte crease, which are just near the brow, it might be very difficult for you to remove the full lesion through a Litte crease incision only, because you may need to do a lot of dissection superiorly. And so for these lesions, you may need to put a sub-brow incision, or you may need to place suprabrow incision. So in this patient, you've done a sub-brow incision right on top of the lesion, and you can get away with minimal scarring as well, but not as good as a Litte crease incision. And again, for this patient, got a very large dermoid cyst, might be very difficult to remove it through only a Litte crease incision. So we have done a sub-brow incision in this patient. Again, you can see a very large dermoid cyst superior to the brow. So you'll have to do a suprabrow incision just near the brow, taking care not to cut the brow hairs. So these are the different approaches by which you can remove anterior place incisions. And one more approach which we don't employ that often is the Litte split incision. So this patient again has got eccentric proptosis. You can see the globe pushed downwards, and on CT scan you can see a large cyst. And if you see closely in the coronal cut and in the sagittal cut, you can see the scolex which is present inside the cyst, which denotes that this is a cysticercus. So since it was pressing the globe, we employed the Litte split, the vertical Litte split incision, where you split the lid vertically in the junction of the medial 2/3 and lateral 1/3, and you can directly access the lesion. And this is how the patient looks after the surgery. So these are the ways in which you attack the anteriorly and the superiorly placed lesions. What do you do for lesions are medially placed? For the medially placed lesions, you have a variety of approaches. You have the medial Litte crease incision, you have the Lynch type, DCR, transcaruncular, and the transconjunctival incisions. So for example, you see this patient has got a anterior superior lesion placed in the medial orbit. So you can place a medial Litte crease incision. You don't need to put a full Litte crease incision. You place the Litte crease incision medially, and you can access this lesion easily. You can see he's got a large cystic lesion in the medial orbit, and these can be easily removed by the medial Litte crease incision. So this is the, for some patients, you'll have a very medially located incision almost near the nose, And for these patients, you might need to employ the Lynch type incision, which extends below the brow and extends onto the medial canthus. But this incision is not a very preferred incision because it leaves significant scarring. And you can see a dermoid cyst has been removed by this incision. And for patients who've got lesions below the medial canthus, you can do a simple DCR type incision where you make a curvilinear incision along the medial canthus, and very similar to a DCR incision, and you can get away with good scars. You can see again a dermoid cyst, you can DCR type incision being placed and the lesion has been removed. For medial intracorneal lesions and lesions are placed in the medial part of the orbit, you can also do the transconjunctival incisions, where you can see you make a squint type incision and you gain access to the medial intracorneal space. For patients with idiopathic orbital, for benign intracranial hypertension, where they have elevated intracranial pressures and they have significant collection of CSF around the optic nerve, which causes papilledema, you might need to do an optic nerve fenestration, for which this approach is very good, where you do a classical squint type incision and reach the medial rectus. You can detach the medial rectus from the insertion and gain access to the medial intracorneal space, through which you can bluntly dissect and reach the medial part of the optic nerve, where you can do your fenestration. This is a very elegant approach and causes very minimal scarring. Again, the transcaruncular incision is also a good incision to access the medially placed incision, especially the subperiosteal ones, because this is hidden within the plica and the junction of the plica and the caruncle, and leaves very good scars. This can also be employed for patients who've got pure medial blowout fractures, and also if you want to do a medial decompression, you can employ this incision. In this, what you do is you make an incision at the junction of the caruncle and the plica semilunaris and bluntly dissect till you reach the posterior lacrimal crest. And once you reach the posterior lacrimal crest, you can make an incision on the periosteum and reach the medial subperiosteal space. And you can identify the fracture or identify the lesion. You can do a biopsy and you can gain access to the medial subperiosteal zone easily. And you can see this patient has got a medial blowout fracture, which has been repaired with the titanium implant. You can see here a titanium implant has been placed and done to the transcaruncular. The advantage is you get very good scarring and almost invisible scars because it's placed in the caruncular region. And this is a short video on this procedure. And this approach is a very elegant approach, and you practically can get away with a single absorbable suture. And you make an incision first in the region between the caruncle and the plica, and then bluntly dissect through the incision till you reach the posterior lacrimal crest. This part of the surgery is usually done through more of with a tactile feedback, and it's a sort of blunt dissection. And once you have reached the posterior lacrimal crest, you can make an incision in the periosteum there and elevate the periosteum and gain access to the subperiosteal space. And for this patient with a medial blowout fracture, we are actually placing osteopore implant, which is a bioreabsorbable implant. So you can cut and shape the implant and place it to your incision. So once the implant is ready, through the incision, you can place it right into the fracture site. And once you're happy with the closure, you can place 1 or 2 absorbable sutures there and close the incision. The advantage of this is you actually don't need to make a skin incision at all. It's a completely conjunctival incision. And you can see at the end of surgery, the patient looks almost like he's not been operated. And the advantage is you get very good scarring. For example, this patient has got a medial blowout fracture of the left eye. You can see he's got an entrap muscle, and you can see the eye is not moving at all, the left eye. And you can see he has been repaired with the transcaruncular approach. And you can see the patient has got a complete recovery of movement on the left side. And absolutely no incisions anywhere on the skin at all, almost like a virgin eye. So that's the advantage of the transcaruncular approach. No skin incisions, very good scarring. Coming to the laterally placed incisions, which are very important from the exam point of view, you can approach the large tumors in the intraconal space through the lateral orbitotomy approaches. You can either make an extended Litte crease approach like what I was telling you, or a lateral canthotomy type of Burke's Cronlein type of incision, make an extended lateral canthotomy incision, or you make a lazy S incision, which starts sub-brow and then extends all the way like this. So these are the different incisions which you can make to gain access to the lateral orbital wall and the intraconal space. So for example, in this patient who's got a large cavernous hemangioma, this might be very difficult to remove only through a transcanonical approach because of the size of the lesion. So you might need to take off a little bit of the lateral orbital wall as well. And so for this, you need to reach lateral orbital wall. So you do the extended Litte crease incision. You start from the central Litte crease and extend it along one of the smile lines there. And you gain access to the lateral orbital wall. The lateral orbital wall and the rim, you mark the lateral orbital wall. You saw it off and you take off the lateral orbital wall. You open the periorbita, following which you'll gain access to the lesion, and you can bluntly dissect the lesion and remove it with a cryo or blunt dissection. So you can see this patient has got a very large proptosis because of intraconal cavernous hemangioma, very huge lesion. You can see the gross proptosis here. And we have done lateral extended Litte crease incision. And we are removing the lateral orbital wall after incising the periosteum. And once you've removed the lateral orbital wall, you make an opening in the periorbita. And once you open the periorbita, you can actually see the lesion, the giant cavernous hemangioma. And then you can use different blunt dissection techniques. And you can see the vascular stalk through which the cavernous hemangioma is attached. So this needs to be cauterized before you remove the lesion. So you cauterize it and then you cut it. And you can gain access to all these large lesions through the lateral orbitotomy approach. You can see the really a big size of the cavernous hemangioma. And these lesions can be removed through the lateral orbitotomy. And like I said, if you place your incision correctly, you can get away with very minimal scarring. And off late, we also do bone sparing orbitotomy, where we, as much as possible, we try not to remove bone. For example, in this patient with a very large lacrimal gland lesion, pleomorphic adenoma of the lacrimal gland, a very large lesion in a very young girl, we didn't want to remove bone. And so it is possible for us to remove certain lesions without removing bone itself. So we make an extended Litte crease incision. And once you do an extended Litte crease incision, you dissect it all the way up to the bony orbital rim, the supralateral orbital rim here. And then instead of actually removing the bony wall, what you can do is you can actually open up only the periorbita and access the lesion directly and bluntly dissect it out. So you're opening the periosteum now. This is the superior orbital rim. This is the supralateral orbital rim. And we are dealing with the lacrimal gland lesion. So once you make an incision into the superior orbital rim, we are dissecting the periosteum. And once you remove the periosteum, and you're seeing the surgeon's view from top. No, so this is the upper lid. Yes, sir.
The slide is not advancing.
So can you see the video, sir? You can't see the video?
No, I'm not able to see the video.
Okay, fine.
Why?
Okay, I think I'm swiping on my Mac. I think that is not screen sharing.
No, here it is stuck
okay.
on.
Stuck on that. Yeah.
Okay. Yeah. So you're not able to see this video.
No.
Yeah, fine.
Video now. The cavernous patient.
Okay. So that video, I think.
Hemangioma is there.
Yeah, I think that that is on a different screens. I think that is not being shared. Okay. I think you can share only one screen. So I'll skip that video. I'll come to the next one.
No. You can show that video. Why?
Actually, this one seen your okay. I think I can your screen share is paused. Okay, 1 minute, sir.
No, if it's not possible, go to the go further. No problem.
Can you see it now, sir?
No, we're able to see only the title. We're not able to see the video.
You will have to stop this PPT and
Yeah,
then
and okay, I think to find we'll go to the next one then.
No problem. Go to the next one.
Yeah. So for example, the same lateral canthal incisions can also be used to remove lesions on the lateral orbital wall like this. For example, hemangioma of the lateral orbital wall.
Yes.
Yeah. So what you can do is you can see you made a lateral canthal incision and you can directly access the lateral orbital wall there and remove the involved region of the lateral orbital wall. That's a hemangioma on the lateral orbital rim. And you made a straight lateral canthotomy type incision. And the inferior orbital lesions can be removed with a transconjunctival approach, even blowout fracture. Suppose you have a fracture of the floor. All these lesions can be approached with a transconjunctival. Previously, we were using the subciliary, where we make an incision below the lower eye lid, just below the eyelash. But now we mostly employ the transconjunctival incisions. And in the transconjunctival incision, you make an intratarsal incision. And I'll show you a video on the procedure, how we approach the inferior orbital rim and how we go to the floor. You can see in this surgery, what we do is this patient has got a blowout fracture of the left eye. He's got an inophthalmos and hypophthalmos. So the plan is to do a transconjunctival incision and reach the floor of the orbit. So what you do is you evert the lower lid and you make an infratarsal incision. So you see the tarsal plate. So you make an incision at the lower border of the tarsal plate. So once you make an incision at the lower border of the tarsal plate, you dissect the conjunctiva off and you go in front of the septum. You do a pre-septal dissection. So you keep the septum intact. You don't want the fat prolapsing out. And you dissect all the way till you reach the inferior orbital rim. So we can see the inferior orbital rim here. And once you have reached the inferior orbital rim, you make an incision in the inferior orbital rim. You make a periosteal incision and then lift the periosteum to gain access to the floor. And in this patient with a fracture, you can see we have accessed the floor of the orbit. We can see the fracture there. We can see all the margins of the fracture. And once you have identified the fracture, you can shape your implant and you can treat the fracture. And also for lesions which are arising from the floor of the inferior orbit, you can employ the same approach. So again, the advantage is you can get away with a very minimal scarring. You just need to either place 1 or 2 absorbable sutures or place no suture at all. It heals very well. You can see after surgery, the patient gets a very good cosmetic outcome. And again, these are patients who have gone the transconjunctival surgery done. You can see floor fracture with the entrapped inferior rectus. You can see complete restriction of elevation in this young patient who's got a white-head blowout. You can see no elevation of the left eye. And you can see after the transconjunctival repair, you can see a complete recovery of elevation. We have freed the inferior rectus and placed the implant there. The advantage, again, you can see there's no skin incision at all. Very satisfactory cosmetic outcomes. So this you can use for lesions, vascular lesions, and structural lesions on the inferior orbit. So you don't need to make skin incisions. So again, this patient has got a transconjunctival incision. We have removed a very large vascular lesion of the inferior orbit. In some patients where you feel the lesion is very large or got pre-existing injury to the inferior lid, where you already have an open skin incision there or a previous scar there, you can make a subciliary incision and access the inferior orbital rim and do the same surgery. And in some patients who've got apical lesions, like in this patient who got lesions very close to the apex, it may not be possible for us to only approach these lesions through the ocular side. And in such cases, we may need to take the help of a neurosurgical colleagues. We might need to do the bicoronal approach where they make an incision on the scalp and reflect the scalp flap and gain access to the apex of the orbit. Like here you can see, you make a bicoronal incision, you reflect the scalp flap, and you get panoramic exposure to the superior orbit. So these are the various different types of incisions. These are different approaches by which we can remove orbital tumors. And depending on the site of the lesion, the size of the lesion, the age, and the type of the lesion, we'll have to titrate the surgical approaches and choose the one with minimal trauma to tissues and best cosmetic outcomes. Thank you all very much.
Thank you, Sendil. Well done. Very comprehensive presentation.
Yeah.
Is Mohan coming on stream?
Yeah, I'm just sorry. I just had to go to the restroom. And Sendil, thanks a lot for the wonderful presentation. It was really nice. It was really complete. And the approach to orbital tumors. I want to take the opinion of the panelists. First, we'll take Dr. Raghavan Sampath online. Dr. Raghavan Sampath, can you tell me can you add or to the whatever Dr. Sendil has spoken?
No, he presented a very comprehensive series, and we tend to see our commonest orbital malignancy we see is lymphoma, and commonest benign lesion we see, I'm sure, in both sides of the world is cavernous hemangioma, and we see multiple various tumors, and there are orbitus. Obviously, I will be saying this is one of the most fascinating areas of ophthalmology, and Sendil is experienced, and he's clearly shown how complex patients he's dealing with. But what fascinates me always is it's so obvious on the scans, and when you go into the orbit, it's not that obvious. I'm sure some of my senior panelists may or may not accept or agree with me. The scans pick up the fluid content of the area and the difference between the lesion and surrounding. That doesn't mean it's the actual lesion. So it's amazing how it's so obvious in the scan, and you go in there and you have difficulty finding the lesion. That's nothing wrong with you as a surgeon, but that's how the pathology and the area is. That's number one. Number two, in the orbital trauma he has shown, we have surely moved towards using 3D printed titanium sheet implants, not titanium mesh, but titanium sheet implants for all our orbital trauma work where they need surgical correction. And obviously, investigations may be slightly varying from different parts of the world, but approaches are very similar. We tend to do, as Sendil pointed out, anything in the inferior orbit, we will go through the conjunctiva. Anything in the superior orbit, we'll go through the skin crease. Slight variation to what Sendil said. I'm able to go up to the middle of the forehead with the skin crease incision. So I will not make any incisions below the brow, on the brow, or above the brow if I can avoid it for any lesion. Most lesions I'll be able to approach through a skin crease. As he also pointed out, lateral orbitotomy, bone removal, we do less, but sometimes it's safer to remove bone and take the lesion out rather than trying to go through a smaller incision, which means you spend more time moving structures around, which raises the risk of postoperative edema and bleed, etc. So if I need to, I would rather take bone away and give myself more room than not take bone away. And most importantly, as all orbital surgeons will agree, there's a massive risk to the vision, ocular movements, unpupil, uninfraorbital analgesia, or anesthesia following any orbital surgery. You need to be hyper careful when you're taking an orbit patients for surgery. It's not to be taken lightly, both by the patient and by the surgeon. And the best way to avoid all the risks of following anatomical lines, giving yourself more room and time. We always insist on seeing the patients post-op before we change and go home. Check the orbit is not tight, check the pupils are reacting, check the vision. I don't believe in firmly padding the patients up after any orbital surgery. I want the vision and pupil to be checked every hour for 6 to 8 hours. And I want to be available close by if needed. So orbital surgery not to be taken lightly. I will end there. I will wait for the other senior panelists to comment.
I think, Sampath, you are given the golden rules as far as orbitotomy is concerned. And we have seen you practice that in Rajanaikar as well. Whenever you do an orbitotomy, all the protocols are strictly followed. And it's very important for all the oculoplastic surgeons and ophthalmic surgeons to follow this. Let's take the opinion of Dr. Gangadhar. Gangadhar, what's your take on this talk and also your approach to the orbital tumors?
Thanks, Mohan and Senthil, great talk. Before I answer, can I ask you what is the rest of the program like and how long more, and do you have any other talks? Then we know.
No, it's only one talk. Senthil's talk is only one talk, and now we have the panel discussion.
Very good. And how long?
After the chat.
How long do we have?
We have got another 20-25 minutes to go.
Wonderful. Because you can see on the chat, there's a poll going on.
Yes.
You should take a look and actually making it interactive so that we have delegates from so many countries.
Yeah, I saw that as well.
Rajanaikar conference. So I'm trying to get an interactive thing going on the site.
Yes.
So we can keep looking at it. I think Senthil did a great job, covered everything. And I think a lot of people who have logged in are practicing oculoplastic surgeons. It'll be nice to pick their brains also on pertinent questions, including Mukesh, Dr. Omar Khan, Harnavita, Pirana, and so on and so forth. Two aspects that I wanted to mention was, number one, yes, we are talking about surgical approaches, but before you put your knife on the patient, about 80-90% of the cases, especially if you get to Raghavan Sampath's level, 100% of the cases, the diagnosis is made as you see the patient and you see the CT scan. So which means like examples of say thyroid eye disease or orbital inflammatory disease or a lot of other conditions, you actually don't need surgery. It's a clinical diagnosis. A lot of times combined with radiological diagnosis, you end up managing it. So surgery becomes a minority itself. An aspect of intervention or invasive procedure for diagnosis, because diagnostic approaches to the orbit are slightly different from therapeutic approaches to the orbit, is a role of needle biopsy. We used to call it FNAC, fine needle aspiration biopsy or cytology. But a lot of times we don't do the aspiration. We actually do a fine needle biopsy or what we call as a core needle biopsy. That's specifically useful for where you suspect metastatic tumors or locations where the lesion is so small, it's not worth doing a major orbitotomy procedure. Either by blind procedure or CT guided, you can do a needle cytology itself. When you're a beginning surgeon, and I know there are a lot of very mature surgeons in the audience, it's always safer to start off with large incisional approaches because you want to have an open sky approach. It's like learning extracapsular cataract surgery. So you get into the orbit, see everything from different perspective, like a Gray's Anatomy textbook, from anteriorly, from laterally, from posteriorly, from inferiorly, from superiorly. So you define the lesion well before you yank it out. Progressively, as you mature as a surgeon, you'll evolve towards minimally invasive or small incision approaches. But every once in a while, we plan a small incision approach and realize we're struggling. Pupil starts dilating, then you stop. Then we end up going to a larger incision approach and doing it as well. So it's important to keep that incisional perspective in mind. Little English correction, Senthil, if you don't mind. We all used to use the term cavernous hemangioma. What do you think you would call it now? Is it really an oma? Is it really a tumor?
It's a hamartoma.
Yeah, it's a venous malformation, right? So cavernous hemangioma is an obsolete term. It's now called a solitary encapsulated venous malformation. And if there's a little lymphatic component, you can say predominantly venous malformation. But for textbook purposes and for listing purposes, you're doing an orbital tumor, which is a space-occupying lesion. Hence, it's called a cavernous hemangioma, but now we're starting to call it as solitary encapsulated venous malformation.
Well, slightly talking on the same subject of vascular malformation, a solid one called used to be called cavernous hemangioma. We get patients for urgent opinions because they've had a scan for something else and they've picked up a lesion in the orbit. That's the commonest way it presents. And at least in United Kingdom in the NHS, we will not take a cavernous hemangioma for surgery unless there are clear indications like optic nerve function change, color vision change, visual quality change, significant serious proptosis. Otherwise, we will not go into the orbit to take the lesion out. So more often, it is picked up when scans are done for other purposes, and majority of them do not need surgery. I'll stop on that subject. Thank you.
Thank you.
So that group of tumors is now called incidentalomas.
Incidentalomas.
So you incidentally find it on CT scan. I'll move on to the other panelists. Go ahead, Mohan.
I hope it's not corona hemangioma. No. Gangadhar, I just want to thank you for the wonderful comments you have made. Very useful as well. And what is the most common orbital tumor you see in your in that area in Southeast?
Yeah, I agree with Sampath. If you're dealing with adults, we are predominantly dealing with lymphoproliferative disorders. And I don't call them lymphomas because unless the pathology comes out. Whereas as in children, I think the usual spectrum of dermoid, which Senthil beautifully showed, I think that's probably what it is.
Okay. Now let's go on to the next panelist, Dr. Mukesh. Mukesh?
Yes, sir.
Yeah. I just want your opinion on the talk by Senthil, and also what exactly is your experience as far as the orbital tumors is concerned.
First of all, let me compliment Senthil here.
Can you be a little louder, Mukesh? Yeah.
So first of all, let me compliment Senthil here for his wonderful talk and very comprehensive talk. He has covered almost everything. And a few of the very important points which Dr. Gangadhar has also highlighted and also Dr. Raghavan Sampath has highlighted. I think in orbit, there are situations when we feel that diagnosis is straightforward and also surgery should be very straightforward. But these tumors can be sometimes very deceptively difficult to remove. Sometimes we feel that we may not have any adhesion in the tumor, but when we try to remove it, we find a lot of adhesions. So orbit is a very difficult area to operate upon. And in some of the cases, what I use is push and pull approach. For superior tumors, I also make an inferior incision in the conjunctiva, transconjunctival incision, just to push the tumor superiorly towards the main incision. So it gives me added leverage, basically. So this is one different thing which I have started doing nowadays for posterior tumors, push and pull approach, and I make a different incision 180-degree opposite to the main incision. So that's one thing. Secondly, as Dr. Raghavan has very validly said, that for small lesions and benign lesions like cavernous hemangioma, small setting, just incidentally radiologically picked up, I don't think they require surgery. And larger lesions are easier to remove in orbit. Though for a person who's not dealing with orbit, he may feel that a very large orbital tumor is difficult to remove, and a surgeon has done a wonderful job. But it is the smaller lesion which is more difficult to be removed. Small lesions sitting in the apex are really difficult to be removed rather than a large lesion. So a benign lesion, small lesions sitting in apex may create problem in removal rather than leaving them there. So I think that was a very good message which was passed on by Dr. Raghavan and also by Dr. Gangadhar. And one thing which is different in India than I think the UK and Dr. Gangadhar also, we don't see lymphoproliferative disorders that much that it becomes number one tumor in our setup. So we do get these cases, but I don't think they are number one incidentally in our setup.
What is number one in your setup?
Yes.
What is number one?
For
number one in Mukesh setup is Mukesh.
I think
Yeah.
Adult patients, I think cavernous hemangioma is the #1 benign lesion which we do get here. Besides the thyroid, actually, thyroid diseases are the most common diseases, but we don't treat them as a tumor. So if we
Yeah.
talk about the benign tumor, then cavernous hemangioma is the most common adult lesion which we are getting in India. And in children, of course, the spectrum is different. But it is that way basically. In children, we do see orbital cellulitis quite a lot and orbital abscess quite a lot. So this is my take on orbital tumor. Thank you.
Okay. Thank you. Thank you very much.
Just while talking on,
hello.
before I forget to mention, during the COVID in the last 3 months, normally we used to see quite a few orbital stroke preseptal cellulitis. I think because of physical distancing and isolation, the incidence of preseptal cellulitis and orbital cellulitis has dramatically come down in children during this pandemic lockdown.
What is the reason for that?
I think lack of physical contact and isolation has stopped these children getting bugs from others, I would imagine.
That's very nice. So that's actually another benefit of lockdown.
But it may interfere with immunity development. I don't know.
Anyway, we'll go to the fourth panelist here, Dr. Preeti. Preeti Uday has got a huge experience in orbital tumors and orbitotomies as well. And Preeti, I want your opinion on this Sendil's talk and how differently you will manage these orbital tumors.
Yeah, I think Sendil has shown a lovely series of cases. It was an excellent talk. A few points that I'd like to stress is any orbit patient, first of all, I think is the pre-op diagnosis on the scans of the patient. So many a times we see very commonly cysticercosis, we see very commonly capillary hemangiomas, and these really do not need surgery. And therefore, pre-operative diagnosis is very important. We should not jump in and just take a biopsy or intervene without that. So I think for the PGs who are here in this group, a training into radiology, how to read a CT scan, MRI, and also few clinical signs that indicate what the lesion is very important. So if there is any question from the PGs here regarding how you would go about it, maybe we could take a few questions towards the end. Secondly, I would like to say that consent before orbital surgery is so important. When we take up any case for orbit, we always discuss with the patient the chances of persistence of diplopia, especially in very long-standing cases, and how long they will take to recover in that aspect, and also chances of loss of vision. So every patient that we touch the orbit, I always tell them that what are the chances? Like if it is near the optic nerve, the chances are high. If it is away extracornal, we tell them the chances are low, but always when we enter the orbit, there is that small risk and that has to be explained to the patient. Also, a common case that the PG students can get or early surgeons can get is capillary hemangiomas. And these are the lesions that we must recognize, and these are now treated with just systemic medication, not even with intralesional that we used to give earlier. So recognition and distinction between capillary hemangiomas, lymphangiomas, other vascular lesion is important. And I think most of the time when we see a lesion, we should not forget the eye. Do the refraction for that patient, because as we know in capillary hemangiomas, lymphangiomas, if the child has no refractive error, if there is no visual deprivation, if there is no increase in cylindrical power, we can wait and watch. So these children do not need early intervention. So, and that is what we see commonly in the OPD. Very rarely these kids need intervention. And that has to be not forgotten. You must do a complete detailed ophthal examination, including refraction, even in a small child. And I think that's about it. Even cysticercosis, sometimes I have seen so many patients coming to us with a lesion and they have been referred for orbitotomy, but it's a simple cyst and you can just give albendazole and steroid and they are all right. And another thing that I would like to stress on is the biopsy. We see a lot of patients who have had biopsy and they come and they say it was non-specific inflammation. And then we repeat the biopsy and we find the diagnosis. So when we take the biopsy, make sure that you're deep enough into the lesion you take at different levels, superficial, deep, as well as intermediate, so that if you encounter a necrotic tissue or if it is just inflammation, still you will have the actual diagnosis in your hand. So a good biopsy is what is needed when you go in for an orbital biopsy. I think that's all I wanted to add to the talk. Thank you.
Yeah, very nice, Preeti. I think you have highlighted all the important points, how to be very, very methodical in an approach to an orbital case. But I just want to know, what do you do for idiopathic orbital inflammation? Do you straight away start the patient on steroids, or do you do a biopsy? What do you do actually?
So it is,
I want your
again,
opinion of all the panelists as well as the Dr. Senthil as well.
so I think first of all, history is very, very important. Whether it is really suggestive of idiopathic or orbital inflammation, history of pain is an important thing. In that, most of the time when it is non-specific, when it is labeled as IOID, it could be thyroid, it could be other disorders. So there are a whole list of the symptoms that will distinguish IOID from thyroid, which is the commonest differential diagnosis that we see in these patients. And I have a very low threshold of biopsying these patients, because many a times, like Dr. Sampath always shows his series of lymphomas, most of the time when it is just considered to be idiopathic orbital inflammation, you can get lymphoproliferative. So whenever in doubt, when the presentation is not typical, maybe you should go in and biopsy and then treat it as a IOID.
Because I want Senthil's opinion on this.
Yeah, I do feel the same, sir. Usually what we do is we don't biopsy in the first time when we see the patient, we don't biopsy. If it's a unilateral presentation like a myositis or something like that, we don't biopsy immediately. So if it's unilateral idiopathic orbital inflammation, usually we treat them with anti-inflammatory, with steroids, and we see how they respond. But if they have a repeated presentation, if another 6 months later they get one more attack, or they got it 2 times a year, then definitely we go and biopsy. And our threshold to biopsy is much lesser when we have a bilateral presentation. We have a bilateral idiopathic orbital inflammation, then we biopsy much earlier. But having said that, what I would like to say in the Indian scenario, our positive rates where we have detected a malignancy or we have come to any specific diagnosis for a patient with idiopathic orbital inflammation has not been that much. Most of the cases where we biopsy, the report which we get is again non-specific inflammation. That's what we get. So we are forced to again beat around the bush. Maybe our histopathological, the pathologist, we don't know. We have to discuss with them regarding this.
The reason I asked that question is because Sampath always believes that biopsy should be done. That's why I wanted
let me sorry, I may need to talk for a few minutes on this subject because it's a massive subject, idiopathic orbital inflammation. So age is important and the way they present. You will not diagnose idiopathic orbital inflammation without certain symptoms and signs. Symptoms, pain. If there is no pain, it's unlikely to be inflammation, number one. It's usually subacute presentation. They will have ptosis rather than a lid retraction. And obviously in a patient who presents with signs of inflammation and pain and a little bit of ptosis and some sign, redness and etc., you will do baseline blood tests, which will involve all the autoantibodies, the previously called vagueness, and then everything, sarcoid, TB. You need to do a battery of tests. And on the scan, if it is diffuse inflammation, or if it's some lesion in the posterior orbit, or it involves myositis, we will not biopsy. If it is an obvious lacrimal gland, and it's not acute dacryoadenitis type picture, then if it is acute dacryoadenitis type picture, we'll treat them with antibiotics first. If it doesn't settle, we'll biopsy. If you're giving them steroids, it's very important to follow certain protocols and make sure that you are not actually suppressing the signs of a tumor in a patient who potentially has a tumor. So idiopathic orbital inflammation is a diagnosis of exclusion rather than a primary diagnosis. Any other situation, I will biopsy if it's a lacrimal gland enlargement or if it's an anterior orbital lesion, obvious orbital lesion, which will not do too much harm if you biopsy. I would biopsy, undo battery of blood tests, and give them steroids. And if it settles down, and obviously depends on the histopathology, And if they need steroids and the histopathology confirms it's idiopathic inflammation in spite of subjecting them to battery of tests, including molecular genetics, which we routinely do on all the biopsies. If you need to give them steroids, nobody should be on steroids for more than 3 months. And if you need to taper and stop at 3 months. If at 3 months, if they get breakthrough inflammation, you need to go through the diagnostic cycle all over again. Do not keep patients on steroids for long. If they need steroids for more than 3 months, you're missing something there. I'm not saying there is something else, but you need to make sure you're not missing anything. Idiopathic inflammation, a tumor elsewhere in the body can present as a sign in the orbit with inflammation, though the cancer is somewhere else. It could be prostate, it could be lung, it could be kidney, anything, anywhere. So sometimes we do a PET scan on all of them. So it's a very difficult diagnosis, not to be taken lightly. Just don't dump them on steroids without clear protocols in your mind and keep on revisiting the diagnosis.
I think it's a beautiful, what do you call, point what Sampath has mentioned. I want Ganga's and Mukesh's opinion on this as well.
Actually, Mohan, if you don't mind my interrupting, there's a question on the side from Dr. from Chitrakoot about vascular malformations.
Yeah.
Is it okay if we address that?
Yeah, please address that. Yes.
And because that's a very challenging thing, I think Raghavan or Sampath also mentioned it. We have the superstar of Indian oculoplastics in your group there, Dr. Lakshmi Mahesh.
All right.
Believe it or not. Can we have Lakshmi come in and address the question of how do you approach vascular malformations and
pleasure to have you, Lakshmi, here
of the orbit?
Thank you very much, Lakshmi, for joining here. Lakshmi. Yeah, Lakshmi, you're able to hear me?
Thank you very much. Good evening to all.
Yeah.
Good evening to all. Thank you, Ganga. No superstar. Please. First of all, I think, instead of arranging blood and getting worked up, when you see a very vascular, Preeti clearly said that hemangiomas are very common in children. Agreed. They're brilliantly vascular. When you do a scan, every single bit of the tumor just brilliantly pops up and you don't have one exact feeder vessel. Now, whatever it is, the venous malformation, which Ganga has beautifully pointed out, is no longer called cavernous hemangioma. I agree with Mukesh that it's the commonest tumor between the ages of 20 to 40, or maybe even up to 50. But after 50, I think we are having more of lymphomas. I would agree with Dr. Raghavan Sampath in that we see more of lymphomas. And now, as far as the vascular lesions are concerned, if you see a brilliant feeder vessel, it's better to get an MR angiogram done first. And if you see a brilliant feeder vessel and you want to tackle the feeder vessel straight away, wherever it is, better to use the good offices of these hybrid OTs which are available now. You have interventional radiologists in almost every city and town. You have neurosurgeons who are doing interventional radiology. And I think Preeti also is working very closely on that. Most of us have access to that. I think we should use their good offices. Just tackle that single vessel which is supplying the lesion and straight away go in and see whether you can cauterize it or ligate it or if necessary plicate it or complete if necessary if it's a CCF. So I think my approach on vascular, because I've had some bitter experiences in the past where I've had to do multiple surgeries, transfuse units of blood, still have residual lesions. And when they come back to you with the residual lesion, you cut a very sorry figure. I think we have to use these hybrid OTs now.
Absolutely. Very nice.
On the same subject, if I can ask the other panelists, we are slowly gone back to bleomycin again after all these fantastic newer drugs. Ganga?
Yeah, I agree. I mean, that is for lymphatic malformation. So to, again, broadly classify vascular lesions, we talked about true tumors. That's where the infantile hemangioma, even the capillary hemangioma now, depending on whether it's seen after birth, is called an infantile hemangioma, as opposed to right there on the day of birth is now called congenital hemangioma. Because the natural history for these two is completely different. So we leave that out. And the rest of it is what is called malformations. And for the malformations, they can be purely lymphatic malformations. This is what we used to call them as lymphangiomas.
Lymphangiomas, yeah.
And they were the nightmares because in the past we were using the knife to treat them. And we now realize that's the wrong way to go. And Sampath has beautifully reminded us the way to now go for pure lymphatic malformations, used to be called pure lymphangiomas, is now sclerotherapy. Again, no surgery on these patients.
Yes.
Under fluoroscopy guidance or whatever it is to do sclerotherapy. Used to be recommended as alcohol, but we are all scared of injecting alcohol in an orbit with a seeing eye. So by default, we are all moving towards bleomycin, requires 2, 3, 4 sittings. And we believe that the earlier you diagnose, earlier you start intervening in them, the better. And in the past, people thought that by starting to give sclerosing therapy, these lesions disappear. We now know they don't disappear. They shrink to a point they don't continue to grow anymore. So that's what we're looking for in terms of lymphatic malformations or lymphangiomas. What Lakshmi is trying to point out is the true group of AV malformations, arteriovenous malformations. These are the very warm lesions, pulsatile lesions.
They are a nightmare.
and you basically will have exsanguination of the table if you don't anticipate it. And those are the ones I agree with Lakshmi. Go for an MRA. I go for even a selective angiogram to find out the feeder arteries. A lot of times it will have multiple feeder arteries, and you work with embolization, and then you can do a debulking. Go ahead, Sampath.
Yeah.
Those lesions, I don't touch them. I send them off to the neurovascular interventional radiologists who coil them, do all sorts of wonderful things to them.
If I may interrupt, Dr. Sampath, your presence will be very vital there. Your presence will be required there.
Yeah. Yes. But I think personally, if I see an obvious the neurovascular, the arteriovenous, high flow arteriovenous abnormality, those lesions I dread surgically. I try my best not to do anything surgical to them. And I involve as many other specialists as possible, because I know it'll end in sadness to the patient and us if we go in surgically. That's been my past experience. So I don't intervene in them myself personally. I get other people involved in high flow arteriovenous abnormalities. Ganga, any comments on that?
Yeah,
I think our friend from Hong Kong has a fantastic lab. I wish I could have something like that. It's never going to happen.
That's a hybrid OT that Lakshmi was talking about. So yeah, arteriovenous, there are two again categories. There's arteriovenous fistulas, which is a classic example is a keratico-cavernous fistula, and thankfully most of them are intracranial. And arteriovenous malformations, which is the nightmare Sampath is talking about. And the purpose of doing a selective arteriogram, and this is again addressing the doctor from Chitrakoot's question is, when you do an initial angio, you will feel one major artery feeling it, and usually it's from the internal carotid. And then you embolize it and you go in, and still is bleeding a lot. Why does that happen? Because these AV malformations have multiple arterial flows. When you block off one, they start recruiting blood flow from the external carotid, believe it or not. And sometimes some very, very small arterial branches, including the facial artery, start supplying them. So the trick is do an angio, embolize one, do a repeat angio, then you find a collateral, you embolize that, embolize all possible arterial inflows into the lesion before you surgically manipulate it. So that's a trick I wanted to tell you. Anyway, Mukesh.
I had a point in this.
Yeah, actually, I
Go
just want to
go to Mukesh and then Preeti, and then one more word from Lakshmi.
Yes, I think that this whole discussion is very valid and very pertinent points have been raised. Just to add few here, that for infantile capillary hemangioma and lymphangioma, role of propranolol has to be stressed. And in most patients nowadays, we are seeing regression in infantile lesions between 2 to 6 years of age. So I think the role of sclerotherapy has been now for selective those who are above 6 years and who have not responded to propranolol oral in infantile age group. That's one point. Second point is whenever we are dealing with AV malformation, I think my interventional radiologist says that the best is to do CT angio than the MR angio, because in CT angio you can pick up tiny connections also, because bone will not interfere that much as it can interfere in MR angio. So I think CT angio is the investigation of choice for AV malformations if we are suspecting. So it's a matter of personal choice also. And again, as Dr. Sampath has also said and Dr. Gangadhar has also said, role of surgery by ophthalmologist is very, very minimum. In these cases, we need to have interventional radiologist services with us. So that's, and the one more point is regarding the treatment of idiopathic orbital inflammatory diseases, as we were discussing. I think now, as Dr. Sampath has also said, steroids should not be given for very long. I also do not give typically steroid for more than 6 to 8 weeks in a go. And my threshold for azathioprine has gone down tremendously nowadays. I am switching over my patients mostly to azathioprine.
Yeah. So I think one point that I want to add is sometimes the capillary hemangiomas are very high flow hemangiomas and they look like AV malformations. We had a patient like that who was referred to us, a small baby, 1.5-year-old with diagnosis of AV malformation. So I feel a Doppler is also very much required in these patients. And if you see a more of solid component compared to vascular component, it goes more in favor of capillary hemangioma, and then you can just try propranolol in these children instead of going in for an intraperineal embolization. So I think Doppler also should be done in these patients.
Yeah. Very interesting. I think you guys both in India and Singapore and Far East are seeing more vascular abnormalities in the orbit than we do in our practice. Looks like from all your comments, we don't do that much.
Yeah. Any comment from Lakshmi?
Yes, sir. I thank Dr. Sampath for bringing about the pet topic of lymphangioma. Dr. Ganga and Dr. Enes, all of us invited Dr. Shuhei Ogita, pediatric surgeon from Japan, who did extensive work in the cystic hygromas, lymphangiomas of the neck and the face, and we used to bring in OK432 and give patients in those times.
That's what we used a while ago, yeah.
Yeah, that was a long time back, 21 years back. But Picibanil worked 50-50, I think. So now bleomycin is really working wonders, and it is here to stay. And even some of these AV malformations who are very scared, we are scared of intervention when they come early and on, and we notice their extensive lesions. I do take the help of the pediatric cardiologist, and I start these patients on propranolol. Even if it is lymphangioma, they have a component of hemangioma which works, the propranolol works. Only when they have a very bad bout of infection or a respiratory infection, when it bleeds and becomes a large chocolate cyst, then we go intervene, take out some of the lesion or drain some of it and then give our bleomycin. So propranolol definitely has a role even in lymphangiomas.
Very good.
Where there is a hemangiomatous component.
Mohan?
Yeah.
There's Dr. Hisar Daniel from Jakarta who's asking a question.
Yes.
Endoscopic approaches to the orbit. Sampath.
Right. In the last.
That's a disadvantage of being the most experienced surgeon in the panel.
Rather the oldest in me. Yeah.
Go ahead, Sampath.
Right. Okay. Where do we do endoscopic approach to the orbit? The obvious ones are thyroid eye disease, which we routinely use endoscopy for that. Do I use endoscopy for anything else other than doing a video of an orbital approach procedure? I would say I rarely use the endoscope exclusively in orbital cases. Thyroid decompression, yes. DCRs, big, yes. But I don't know whether that's part of the orbit, DCRs.
Hopefully not.
Orbit exclusively, do I use endoscope for anything other than thyroid when I augment the decompression medially? I can't think of any situation where I use endoscope to approach an orbital lesion. Exclusive orbital lesion within the orbit.
Trauma in the optic canal, if you have a bone fragment, endoscopic approach is good.
Yes. That's the trauma to the optic nerve and
you have a bone fragment,
surgical approach to a trauma optical nerve with a bone fragment. Is it an
early stage
job or is it an ENT sphenoid sinus approach job? I don't know. It's outside my envelope of safety going into the sphenoid sinus without ENT boys and girls being involved. So I will not do it personally. But the indications are so small. In the NHS, we base on what is available scientifically, the most recent evidence. So we tend to stick to treating them mainly conservatively. and get opinions. If the opinions say they need surgery, they go to a proper skull-based stroke ENT surgeon who's happy going deep into the sphenoid sinus. But I don't have the experience to go into the sphenoid. I'll put my hands up and say it's outside my
optic nerve fenestration?
Optic nerve fenestration, yeah, we do that routinely, not in the sense when there is an indication, obviously. Yeah. And we tend to do, as Senthil showed, removing the medial rectus, going there and taking a little envelope of the optic nerve sheath. The most vulnerable part of the optic nerve which is affected is immediately behind the globe rather than within the optic canal. So I don't know, I can't see the purpose of going endoscopically and releasing the optic nerve sheath within the optic canal. I think the most vulnerable part of the optic nerve is right behind the globe.
What's Ganga's take on that? I know that you are doing a lot of endoscopic, you were doing before.
Right.
Ganga?
Well, that's the reason why I deferred it to Sampath and the other experts, real experts. Well, you know, endoscopic approaches to the orbit have been described, and maxillofacial ENT surgeons do it. Fractures, I think, this medial wall, isolated medial wall fractures, you can use it, and I use it more for demonstration purposes, concept rather than anything else.
That's what I said. For videoing, it's very useful, but not, yeah.
And for the residents to see what you're doing deep inside the orbit. By default, all medial wall decompressions are endoscopic approaches, but every once in a while, you want to show your residents and fellows a purely ophthalmologist way of doing it. We pride in having a multidisciplinary clinic whereby we co-manage diseases with our ENT surgeons. We have a close network of relationships. You now know that all pituitary tumors in most centers in the world are not done by ENT surgeons alone or neurosurgeons alone. They now have a neurosurgeon ENT team which co-manage these things together. As you start approaching these, when you start working with endoscopic surgeons, you become more comfortable. The only situation for orbital tumor, I would use an endoscopic approach, not myself, but with my ENT colleagues, we go in together, is posterior medial tumors. There is literature about radiation therapy, literature about doing a posterior decompression to relieve the compression of the optic nerve by the space occupying lesions. But if you were to really go take it out of a posterior medial tumors, then you could consider that. I mean, that's what I would do. Just my 5 cents worth.
Yeah, I agree with that. Very posterior, very, very deep in the apex. It's always helpful to decompress from the endoscopic side, and then take the tumor as a combined approach, or up to the posterior thing. We can go up to the sphenoid sinus. I'm happy. Beyond, I will not do it myself. I will get ENT, the surgeon involved, who's experienced in that approach.
Let's ask the speaker a question. This is a question again coming from Chitrakoot.
Yeah.
How will you preoperatively differentiate a solitary encapsulated venous malformation, i.e. cavernous hemangioma, from a hemangiopericytoma before you go in? That's a question from Chitrakoot. Because, you know, quote unquote, hemangiopericytoma is an obsolete term itself. It has completely been reclassified, but the occasional vascular ones can bleed like crazy as well. So the question is, how will you know preoperatively? And again, the other experts can comment as well. Go ahead, please.
Yeah, preoperative difference between cavernous hemangioma and a hemangiopericytoma, is it?
Correct. Before you go in.
Before you go in.
It's not my question. It's from the panel. Crowd, which is important, I think.
Yeah. Actually, both of them can present in a very similar way. But I think radiologically, they have certain differences which with which I think you should be able to differentiate both. Usually, I rely on my radiologist to give me that diagnosis. But looking at the CT, I think it's very difficult for you to differentiate between hemangioma and hemangiopericytoma.
Mukesh ji?
Mukesh?
Yes, sir. Typically, I think the history is very informative. These are typically very fast-growing tumors. The age group is also suggestive. Normally, we do get these cases in juvenile age group. So, if on imaging, we are getting a vascular tumor, which is very fast-growing, and it's in juvenile age group, then I think I do suspect them as having hemangiopericytoma. But again, it's basically histopathological diagnosis. But clinically, I think these are the patients where my suspicion for hemangiopericytoma goes very high.
Are we talking about solitary fibrous tumor?
Exactly right. Yeah, go ahead. Go ahead, Preeti.
Yeah, so I think it's the contrast. When you give the contrast, and in cavernous hemangioma, there is a little delay before the contrast starts appearing, and the pattern, it starts from the center and goes to the periphery. But in a vascular hemangioparasitoma, you will have an overall contrast enhancement in the early phases also. So you can make out little bit, but if it is very vascular hemangioparasitoma, I think it's only a pathological diagnosis.
And hopefully not an intraoperative surprise, right?
Lakshmi, you'd like to add anything?
Sorry, you're muted, Lakshmi.
Yeah.
No.
Hemangiopericitoma is a little crazy in the sense it is a little more diffuse. It's not so beautifully confined like the hemangioma. And again, it's brilliantly vascular. It will have a feeder vessel. There will be history of reoperations. The solitary fibrous tumor variant of it, which is usually well encapsulated, it may be multinodular, is not so brilliantly enhancing. But in hemangiopericitoma, it enhances. We have had 1 or 2 instances we had to even go for exentration because they bleed like hell. I think we have to, if there is a suspicion of it, we have to do DSA and straight away go for the feeder vessel. That's the thing.
Any other different opinion? Ganga?
No, I brought it up again because it is very challenging to diagnose. They all look like well circumscribed lesions. Like Sampath pointed out, we don't call them hemangioparasitomas anymore. They all come under the spectrum of solitary fibrous tumors, SFTs. And SFTs can vary in terms of the vascular supply itself, like Lakshmi pointed out, and Preeti pointed out, based on the enhancement, the brilliance of the contrast uptake, you start suspecting is that if there's going to be a high flow, these are the patients, yes, you should possibly even consider a selective angiogram. And there are cases nowadays for the complex hemangiopericitomas or solitary fibrous tumors, they're embolizing these tumors before you excise them. So going back to basics, what Senthil pointed out is back to clinical suspicion. If it does not have the classic delayed enhancement of a solitary encapsulated venous malformation, look for and think of solitary fibrous tumors. They are not as rare as you think they are. And based on the vascularity and the contrast uptake, you can even consider an angiogram. And if you have selective focal vessels, you should consider an embolization before you do it. More often than not, they're very anterior to mid-orbit. You can get away with it. In the posterior orbit, you will end up having a disaster.
Okay, Ganga, can you just find out if you answered all the questions from the audience, from the participants?
There was some question about whether you should do a CT or an MR scan. I think generally for orbit, that's usually a question in most orbital discussions. In our practice, if it involves a neurological, say it's an optic nerve issue, we'll always go for an MR scan, or when you're suspecting idiopathic intracranial hypertension type picture, MR scan. Otherwise, our routine would be do a CT or a CT angio or a CT with contrast, and then add MR on top of it if required. We have no restriction on the scans. And we'll go for CT first because that's easier to get, 90 seconds in and out. And if needed, MR will add on top of that. So you should have a choice of both available for you, and there's nothing wrong in repeating, doing a CT first and then asking for a MR later, because CT is much easier and you want to know the bony anatomy. And if it's a thyroid or something where you want to remove bone, then obviously you would need a CT. CT gives better pictures for certain conditions. MR gives better picture for certain conditions. Central nervous system, optic nerve, MR, anything else, usually CT first. That will be my normal practice, but I'm happy to be guided by the other experts.
Mohan?
Lakshmi?
Mohan?
Yeah.
May I introduce to the crowd whose people joined in a great, wonderful friend and colleague from Tehran,
yes,
Iran, Dr. Farzad Pagdal. I just see him online. Farzad, can you turn on your microphone?
Hi, Farzad.
It's extremely highly academic and very, very, very well published. So we'll probably pick his brain on hemangiopericitoma, solitary fibrous tumors, the vascular tumors, and his concepts and approaches. Before we go to a question from UK, London, how do you replace the orbital rim after you removed it for an intraosseous cavernous malformation? Farzad, take the stage, please.
Can you just unmute, Farzad? Sai?
Yeah, hello. Thank you very much for that wonderful talk.
Can we see you on video as well?
Yeah. I'm trying to get him on the video as well.
He's a handsome young man.
Hello. Yeah, that was really wonderful.
Thank you.
Sorry, can I have your question again?
Approach to vascular malformations to the orbit, and can you differentiate a hemangiopericytoma or the solitary fibrous tumor, which sometimes can be extremely vascular and bleeding on the orbit? And how do you differentiate from a venous malformation, a cavernous hemangioma, preoperatively?
Actually, it's a really tough question. So in terms of the venous malformations, first of all, we need to know if it's kind of the low flow or high flow venous malformation. In those with the high flow venous malformations, you may have valsalva maneuver. You can have the exacerbation of the proptosis, or when the patient bends down, you may see that the patient feels some heaviness and the globe pushes forward. In those with low flow, like now we say lymphangioma, usually you do not see the valsalva maneuver. In terms of the imaging, MRI can show the microcystic lesions. Actually, it's typical for the lymphangioma or those with the low flow venous malformations. But in terms of the high flow, you will see the convoluted channels of the venous plexus in the tumor. And actually, it can be helpful to differentiate with these together. In terms of the solitary fibrous tumor and hemangiopericytoma, many now believe that it's kind of the same tumor, because the IHC are the same in both. But from the actually years before that, many continue to say this is the lymphangioma because the Steichhorn features in the pathology or something. But nowadays we rely most on the IHC, and now I think solitary fibrous tumor and actually hemangiopericytoma are unique and the same entity.
Thank you.
Thanks a lot for the nice inputs, Farzad. And I want, is Lakshmi online there?
Yes.
Lakshmi, what's your take on that?
Yes. Between SFT and hemangiopericytoma, I think it's very difficult radiologically unless you see a more capsulated lesion. I will call it SFT. Little less capsulated lesion, I will call it hemangiopericytoma. I'll be usually ready with a 1 pint or 2 of blood, but these days I find that if we can find something called a feeder vessel, it is much better. We can avoid reoperations because it becomes very messy. Sometimes we have to operate for 5-6 hours, keep monitoring hemoglobin, it drops on the table. And I think with all these problems now we are facing with this COVID and all that, I think we should just go for single shot, sure shot procedures rather than multiple surgeries.
Going to another topic, Lakshmi, I want to, because Sampath raised the issue of doing a CT first and then MRI later. So what do you think? Because we do MRI here regularly, then CT.
When we see the patient clinically, if we find that we are suspecting more of a soft tissue lesion, definitely MRI, no more CT. But as a surgeon, before the surgery, like for instance, thyroid decompression, we want to know the bony contour, how much to take, shape, chisel, model. Then we need a CT scan or a dermoid. We want to know what's happening to the bone, whether it's whether it has invaded the bone, any tumor. Then I go for CT. If in case nowadays the trend is, if we see 10 patients now with orbital lesions, at least 7 we advise MRI. Or 3 CT.
Okay.
Just make a point here, sir. Just one point.
Yes.
So I think doing a CT is actually very important because, like Dr. Sampath was saying, if it's an optic nerve lesion, then MRI is very, very important. But when you're going to, for any other lesions, very important to also have a CT, for example, a lacrimal gland lesion or any lesion for that matter, to know the relationship of the lesion with the bone, with the bony orbit, no? So that we know where is the lesion, what is the relation to the bone, how it is remodeling the bone, or is it invading the bone. So doing a CT is actually very important. And sometimes we see patients only having MRI. And with only MRI, really, you can't actually move forward because you don't know the relationship with the bone and you can't even see bone. So, for example, even with fractures, we see patients come only with MRI. So, because of the fracture, you need to see only bone. You need to see where the fracture is, all that. So, I think like what Dr. Sampath was saying, the CT is actually a first step. And then you need to order MRI on top of that. Then only you'll have a holistic picture of what is the relationship of the lesion to the bony orbit. Then you know where the location of the lesion is and all that. So it's very important to get CT first and then decide if you want to also do MRI after that.
Just to add to that, obviously depends on the presentation. If it's trauma, obviously if it's bony trauma, you'd go for CT. Children with orbital cellulitis or preseptal cellulitis where you want to investigate, obviously you would do a CT just in case first, but repeat scans in children, we'll always do MR rather than a CT. So it's a combination, depends on the presentation, depends on the pathology, but generally speaking, you won't be doing too much wrong by doing a CT first, followed by an MR. In our practice, it's much easier to get a CT scan done than an MR scan. Maybe that dictates the way we work, but it's a fascinating field. So you just if you speak to the radiologist, they'll also give you confusing answers. Sorry, we have confused the people who are not involved in doing orbits day in, day out. There is no straightforward answer. You're not doing too much wrong by doing either, but ultimately you have to get to the bottom of the pathology and deal with it appropriately. It doesn't matter which scan you do first.
Now, what is the take-home message? CT or MRI or both?
Depending on presentation.
Depending on age and presentation, depending on what the pathology you're suspecting.
No, let's put it this way, Mohan. Let's put it this way, and then we'll have a little poll, okay?
Yes.
Simple young adult with unilateral proptosis where you're suspecting most likely thyroid disease. Another 45-year-old with a unilateral proptosis quite orbit where you're thinking of either a schwannoma or a cavernous hemangioma, venous malformation, CT or MR. Lakshmi.
MR.
First, MR. Sampath.
Sorry, I was
simple benign proptosis in an adult. First investigation of choice.
I will, as I said, in my practice, it's so easy to get a CT. I would do a CT first.
Okay, Senthil.
So if it's a thyroid, acute thyroid, I like to do
MR. No, we don't have the diagnosis. Unilateral proptosis in a benign looking eye, 6X, no RAPD. You're suspecting a space occupying lesion. CT scan or MRI? First scan.
I will do a CT scan.
I'll
Preeti.
do MRI. If it is
Mukesh.
soft tissue.
Mukesh.
Yes, I'll also do a CT scan only in an adult patient, especially benign lesion.
Farzad.
Dr. Fasad?
Yeah. Can you hear me?
Yes.
Yes, sir. Yes, sir.
Okay.
CT scan or MRI?
Yeah, CT scan first.
We have Dr. Omar Kind, head of Oculoplastics from Myanmar, Yangon. Can you come online? She's extremely experienced orbital surgeon. CT scan or MRI, first choice. Well, if she's not there.
She's there? Ganga?
Yes, I would say CT scan first.
Very good. So if you have a democracy and we had a vote, so I would summarize saying that a CT scan is a poor man's MRI. Like Sampath said,
I beg to differ on that.
I'm a poor man. So 90%
Sampath is not a poor man there.
Sampath is not, and Lakshmi is not.
Thank you. But last 3 months, I'm a very poor man indeed.
All of us are poor.
So to summarize the answer, CT scan answers 90% of the questions that you need to ask. With modern day CT scan, it takes seconds to acquire a CT of the orbits. CT of the face takes a few extra seconds. It's only how much of a cost is much cheaper. It gives you both bony anatomy and soft tissue anatomy. Fat acts like a natural contrast. So by default, I would probably go for a CT as a first choice if you're thinking of a space-occupying lesion. But if you're thinking thyroid eye disease, but you're not planning to do a surgical decompression, I don't even do a scan nowadays. But if a patient wants to do an imaging of choice, there maybe I will do an MRI, because all you want to know is mostly whether the muscles are enlarged or not, which muscle is enlarged. Then I would do an MR, because in thyroid eye disease, sometimes you may have to do repeated scans, or later on the disease evolves and you may have to repeat it again. Then I think MR is a imaging of choice.
I agree with you, Ganga. I think if it's a straightforward thyroid eye disease, which is obvious and there is no confusion and you're not planning anything dramatic like surgery, I wouldn't scan them at all.
Right.
When there's confusion in the diagnosis, you know that there are certain conditions which can present like thyroid, then I would do a scan. And if you're planning anything drastic like surgery, then I would do a scan. I agree with you entirely.
Agree.
What about the second situation, Ganga? What do you do, MRI or CT? You're talking about cavernous hemangioma or schwannoma?
Probably when you're thinking about solitary fibrous tumor,
Yes.
which is hemangioperocytoma, where the way the enhancement and way the gadolinium enhances in a cavernous hemangioma compared to that. In that situation, or you have optic nerve or optic nerve sheath lesions. You want to differentiate on perioptic nerve versus optic nerve lesions. Then after following it up with a CT scan, I would definitely do an MRI.
MRI.
That's my short answer to a long question.
That's fantastic. Okay. And if we don't have any other questions or suggestions, then we'll close this webinar now. Any other opinion from any other panelists?
I want to thank
Dr. Shruti, sorry, Dr. Shruti is asking a question from Coimbatore.
Yes.
How much do you, all the surgeons, how much do you rely on your radiologist report versus your own radiological judgment? Last question, if you don't mind. Sampath.
Right. As far as orbits are concerned, I look at the scans myself. If anything in the brain, I don't have any, so I get the radiologist to have a look. So anything in the orbit, I'm reasonably confident. But if I'm in doubt, I will discuss it with the radiologist. I think we work wonderfully as a team. We meet once a month and discuss all our cases the previous month and the planned cases for next month. We learn from each other. But within the orbit, I always look at the scans myself. I'm sure the radiologist will not rely on my report, and I will not entirely rely on radiology report. We work together. Orbits, I am happy with myself. Brain, I'm not happy with myself.
Farzad?
Yes.
Yeah.
How much do you rely on your radiologist report versus do you read the scan yourself?
Actually, I was educated first to rely on myself because of based on the clinical findings, then looking at the all imaging, analyzing all data. At the end, I will look at the report of the radiologist to bring some dissonance. I mean, if there is something reported that I didn't look at the imaging, I will look at the gain, and that's me that will judge about the lesion, not the radiologist. If you're asking about the percent, it depends on who is reporting that. To be honest, I don't think in my practice, it's less than 10% actually. Just a very few neuroradiologists I know that I can actually rely on them, but not more than that.
Thanks. Over to you, Mohan.
Fortunately, we have a very good radiologist in Chennai who can interpret these orbital lesions so very well. And she's also attached to Shankar Netralia, and it's really fantastic to have her in that. I wish that she was also here, part of this panel today. But anyway, we had a fantastic webinar. We had a very good panel discussion as well. And Dr. Sendil, hats off to you for a wonderful talk. And all the panelists who made a huge difference as far as this orbit and oculoplasty an approach to orbital tumors is concerned. Again, as you know, this Rajan Eye Care Rio's webinar has been a very successful webinar. It's been a very successful venture. I get the feedback from all the postgraduates and practicing ophthalmologists that is very useful, very informative as well, very practical discussions which are going on in this. So till we go to the next webinar, probably the next week on some other topic, probably pediatric ophthalmology. I'll let you know soon. And this is, I think, Ganga, you want to say something about this? Oculofacial? It is tomorrow. Yeah, Ganga, you'd like to say something about this? Ganga?
You'll have to unmute yourself.
Yes.
Actually, I may introduce this poster as the co-host of this interesting webinar, and all of you, dear friends and colleagues, you are invited to join us for this fantastic case presentation.
Yeah, we are looking forward to that tomorrow. And it's, what time is IST for this, Ganga?
It's 9:30 in the morning tomorrow.
9:30 in the morning tomorrow. Okay.
We're looking forward to that session.
Okay. Till then, see you all.
Thank you all very much. And lovely to see Dr. Lakshmi, Ganga, Preeti, Sendil, and Fazad. We have met a couple of times before. And Mukesh, thank you all very much.
Thank you.
Thank you very much.
Bye.
Thank you.
Thank you. Thank you so much.
Thank you all. And thank you, Dr. Mohan, especially Dr. Mohan, for his enthusiasm and initiative. It's not easy. Really, I appreciate.
Thank you so much,
Thank
Lakshmi.
you.
It's so nice
Thank
of
you,
you, really. And you've been really a fantastic friend of Rajan Aikar, and also you've been part of Shankar Netra for so many years. And you and Mahesh are really a fantastic couple. Thank you very much.
Thank you so much.
Thank you.
Sampath,
Thanks,
thanks
everybody.
a lot.
Bye-bye.
Thank you all. Thank you.
Really
Thank
wonderful.
you.
Thank you, Mohan.
Thank you. Thank
Thank
you,
you.
Raja.
And Preeti.
Thank you.
Mukesh, thank you, Preeti.
Thank you. Thank you. Thank you so much.
Sendil, big thanks to Sendil. That is Sendil. Sendil has disappeared. Sendil,